Welcome, and thank you for having me. Yes, I'm Richard Feely. I'm an osteopathic physician surgeon practicing for 42 years in Chicago, and last month I moved to be by my daughter in Indianapolis, Indiana. And I'll be teaching part-time at Marian University, which is a College of Osteopathic Medicine in Indianapolis here. But previously I was a clinical associate professor at Midwestern University, Chicago College of Osteopathic Medicine. I'm a graduate of the Kirksville College of Osteopathic Medicine, where I did a pre-doctoral fellowship in osteopathic manipulation and was taught by Edna Nalay, Viola Fryman, Paul E. Kimberly, DO, FAO, and he was my chief in Kirksville. So I made my bones basically in cranial osteopathy, where I was president of the Cranial Academy and then later president of the American Academy of Osteopathy. And then a few years ago, I was honored with the A.T. Still Medallion of Honor, which is the highest award given to an American osteopath for exemplifying A.T. Still's philosophy and practice. So anyway, I've been involved in osteopathy, and I practiced right down in the loop, away 2 blocks away from the American Osteopathic Association, across the street from the 7th best hospital in the United States at Northwestern Memorial Hospital. But now I'm living in Indianapolis, and a few years ago, I just discovered or found a different way of doing indirect technique that I call neuro-ocular release, NOR, neuro-ocular release technique, where you get pain relief for neuromusculoskeletal pain in as fast as 3 seconds. So how do we get this pain relief using just our hands on patients that have neuromusculoskeletal pain? And it's remarkably easy, but it's not a cure-all for every kind of pain there is. But I'll show you a demonstration here on just how we're able to get some pain relief.
Neuro-ocular release, a technique that uses indirect methods to unwind the joint mechanical receptors and nociceptal pain fibers that are causing the pain in the body. We use indirect techniques like counter-strain procedures and adding the neuro-ocular release with the eye focused on one spot in the room and then closing the eye, resetting the central nervous system's memory of pain. We'll identify the areas of tenderness over the acromioclavicular joint and then the coracoid process. Is this tender? Yes or no?
Yes.
We take the hand, right hand please, and put the hand on top of the head like this, and turn your head and look at the outside of your elbow. Okay, is this tender? Yes or no?
No.
Okay, stare at the elbow. Now close your eyes, put your arm down, head straight, open your eyes. Is this tender? Yes or no?
No.
Okay.
That one.
Yes, okay. Now put your hand.
So that is
Today we're talking about
that is just easy 1, 2, 3 techniques called neuro-ocular release. So today we're going to talk about neuro-ocular release and what our goals are eventually when we have the course in April. And today we're going to describe how pain is transmitted and how this unique osteopathic technique called NOR can ameliorate the pain in the proposed theoretical neurological mechanism that's involved. I'll talk about 7 objectives that we'll achieve in the course that we're going to have in April that will enable you as the osteopath to be knowledgeable and effective and efficient and proficient in this new technique that eliminates neuromusculoskeletal pain in a few seconds. We'll talk about the definition of who should get this type of treatment, what it is, where do you use it, and how do you use it, and when do you use it, and then more importantly, why would you use it on this patient or not? So we're going to study pain and what it is and what it isn't, the epidemiology, the various types of pain, the neurological pathways, the cellular mediators and actions that occur within the patient that's suffering from neuromusculoskeletal pain. So NOR is an advanced, skilled osteopathic indirect technique that facilitates the removal of neuromusculoskeletal pain and thus somatic dysfunction in a few seconds. skilled because you'll see that this technique, when you're in the lab with me, the course will be at least 50%, could be a 70% hands-on training when we have the 20-hour course. So you'll be involved with a lot of palpatory integration and understanding of what's happening underneath your fingers. That's why an experienced osteopath will be able to do this very efficiently and effectively in a few days, whereas a neophyte, they might not even get it. So that's why it's more an advanced technique, because the subtlety of the tissue texture changes that you feel underneath your finger will dictate where and how you will have to instruct the patient on putting their eyes and their body parts. So who benefits from NOR? These patients that have somatic dysfunction that are associated with acute or recurrent neuromusculoskeletal pain are the ideal candidates. And they also have to be able to follow directions and have some vision. I've had the opportunity to try to do NOR with an enucleated patient that had no orbital contents because of cancer. It was totally ineffective. And then I've had legally blind patients, 2080, 2800, which is beyond legally blind. They were able to be successful, especially when I pointed out to where they're to look, even though they are legally blind. So it was very interesting. And then where do you use it? So it's used for any associated neuro-ocular release tender points that you can find on the 10 body regions. And any type of neuromusculoskeletal pain could be ameliorated by it, and oftentimes is. So I use some NOR when I have a patient that has NOR tender point and somatic dysfunction, and they have neuromusculoskeletal pain, and an indirect technique is preferred as opposed to a direct high velocity technique or a direct muscle energy technique, because the problem is not solely muscular in nature. It's more neurological or more chronic in nature. So you'll find out that when we use NOR, we have the ability to change the memory of the nervous system of the spinal cord area neurologically. And that's what I've found with this technique, because we change the whole neurological system from the spinal thalamic tract to the cortical spinal tract and their interface in the dorsal chain ganglion that's present there. So we'll talk about all those things. So what is NOR in a nutshell? Well, it's an indirect osteopathic manipulative technique that turns off the nociceptal fibers of these tender points, and it activates the central nervous system beginning through the eyes, the ocular system, and then it goes to the peripheral nervous system, and as was originally described in my article in the Journal of the American Osteopathic Association of June of 2020. So it's an indirect manipulative technique that uses the eyes to focus the nervous system into a certain area using various pathways that will go into great detail into the course, so that you'll understand scientifically the theory and how it works and why it's effective in removing recurrent somatic dysfunction. So it works by deactivating the central facilitation or sensitization of that local somatic dysfunction that's either active or latent. So a latent tender point is a patient that doesn't know they have any pain in that area that you're palpating to touch them and put some pressure on it. But an active tender point is a patient that is suffering, and I heard here. So we use this neuro-ocular system in a manner described to inhibit this presynaptic primary afferents, and then the postsynaptic inhibition of their spinal projections. This results in modulation of the pain and diminishes, in most cases, almost always removes the areas of somatic dysfunction. Now, it is primarily an indirect technique, a soft tissue technique. So getting arthrodial restrictions, other techniques are better designed for that. And getting true primary muscle somatic dysfunction, other techniques are better for that. But this works through the nervous system and allows that memory of somatic dysfunction to be reset. Well, the important part for you as a clinician is that NOR is less time consuming, provides a more systematically complete treatment of somatic dysfunction because it affects the fascia, the vascular system, the lymphatic system, the nervous system, as well as affects some of the bones and the muscles of that area. So it functionally removes that spinal cord memory of the somatic dysfunction. That's where we're working at through the periphery. So the goals of NOR is that you'll learn this new osteopathic technique to remove and decrease neuromusculoskeletal pain in your patients, that pain that's originates and transmitted and ameliorated through this unique technique called NOR. So the objective is that the course here that we're going to do is that you'll be able to describe what the pain is, how the pain is transmitted and modulated. You'll be able to recognize and describe the 3 different types of pain and describe what NOR is and get the experience yourself so that you see how it works on your own body. And then you'll be able to learn how to describe how NOR works in the neurological details, and obviously identify the NOR tender points, learn how to treat at least 5 out of the 10 body regions successfully. So that's the goals, the 7 goals of this course that we're going to have. So as you see here, pain is, and somatic dysfunction and OMT is pretty much a continuum. We live in a world of pain, and oftentimes somatic dysfunction is precursor to that pain. And fortunately, you as osteopaths really know how to treat that somatic dysfunction. So as an experienced osteopath, you know, this is the key that you will be involved with: identifying the pain, the somatic dysfunction that's associated with the pain, and then ameliorating it in a few seconds by just positioning the patient in the right way and having them look in the right direction, focusing on one specific spot, either on their body or in the room, and then closing their eyes. And then that resets, opening their eyes resets the whole neurological mechanism. So we're going to learn the different classifications of types of pain and understand how they're transmitted. Well, pain is the #1 problem that physicians see, and our life is filled with pain. And pain is really pretty important because pain is the body's protective system. It helps us avoid environmental threats, and we learn defensive behaviors. So the ideal pain system would activate itself just prior to the use of tissue damage, so that we protect ourselves and not receive that tissue damage that's associated with pain. Now, nociception is a mechanical, thermal, or chemical event activating these small capillary primary afferent fibers following by transduction and then transmission of these noxious stimuli to the brain. So nociception is not pain. So sensitization, hyperanalgesia is found in acute pain. So nociceptors are sensory receptors that respond to tissue damage, as we just said. And these are acute events such as surgery, childbirth, and acute illnesses. But nociceptors have unique response properties. And these cause clinically acute pain states that are different for different types of injuries. Now, sensitization is characterized by the nociceptors in which they respond to the stimuli are enhanced. And this enhancement at the site of the injury makes the body hypersensitive, and sensitization to feeling pain and perceiving pain at a higher rate and a higher decibel if you have it. So nociceptor sensitization produces primary hyperalgesia, and that generates ongoing pain at rest, enhancing pain during and after surgery, injury, and childbirth. So this is the type of pain that NOR is going to be very good at. So we have acute pain, and what happens? We have substances that are released, but we don't know all of them. We do know that prostaglandins are released and with tissue trauma, and this sensitizes the nociceptors. They modulate other chemicals such as nerve growth factor and which increases when we have any kind of incision or laceration. Also, we do know that there's interleukins, cytokines, and acidic changes occur right at the cellular structures. So at the cellular level, we have the biochemical changes, the pH changes, as well as cytokines, interleukins, and other neurotransmitters. So these nerves are hypersensitive and very active. So central sensitization occurs with acute pain when neuroceptive input are enhanced, amplifying other clinical pain symptoms through the central nervous system. These increased responsiveness of the central nervous system to below subthreshold afferent input is termed central sensitization. So the magnitude of central sensitization depends on many factors, including the tissue type and the extent of the injury. These central sensitizations amplifies that transmission from the peripheral tissues, produces secondary hyperanesthesia, increased pain response, evokes stimuli applied to the tissue from outside that area of injury, so they begin to hurt all over. So these biochemical changes that cause central sensitization are what we're going to be treating with our hands. And that's why NOR is unique in its osteopathic approach. So centralization is expressed in a variety of forms, both spinal and supraspinal mechanisms. So how do we get the supraspinal mechanisms? Well, my proposal was to use the eye, the window to the soul. So we had the opportunity to use the eyes to get to the central sensitization and remake the biochemical changes of the CNS into the PNS and heal that patient. So that's some of the story that you're going to hear when we do the course in April. But nociception is not the same as pain, because pain is distinct from nociception in that it includes context-dependent parts. Pain is an emotional feeling. It's a cognitive. It's a behavioral. These are three different types of elements that are involved in what we call pain. And involving pain is modulation and perception. So as osteopaths, how do we help the patient modulate their pain and improve their perception of health? Because after it all, we're an osteopath. We're all about health. We're not about disease. As AT still says, anybody can find disease. Nobody can find health. It's difficult. But you've been trained, and that's our mission as osteopaths, to improve the life of our patients, to see health in our patients and restore health by identifying dysfunction first, and obviously disease if it's present. Well, there's good and bad pain. So eudynia, which is acute pain, protective in nature, expected from tissue damage, and it gradually goes away in a certain amount of time. Malidynia is when the tissue is abnormal in its composition. They have constant nociceptal signaling. The neural pathways are frayed and injured. The cerebral cortex may be fatigued or facilitated. The peripheral nervous system and the central nervous system are facilitated. So this hyperfacilitation that we just talked about, sensitization, is effective in the PNS and CNS. And this NOR technique, we're trying to fix that. So the result of malidynia or bad pain is hyperalgesia, allodynia, and continuous pain. So acute pain is always normal, predictive, physiological, and time limited. And it's always related to chemical, thermal, mechanical stimuli. So this occurs with our illnesses and injuries, and it's often accompanied with that pain because it's a psychological, emotional, biochemical change, anxiety, diaphoresis, nausea, but it always ends. It ends after the stimulus is removed and the organ heals. Chronic pain is a different kind of pain. It is that persistent pain that goes beyond the normal length of healing, and the definition is always greater than 3 months. So we have 3 different types of pain by time. We have acute pain, which is 0 to 6 weeks. We have subacute, which is called 6 to 12 weeks, and chronic pain, which is over 3 months. As DOs, we see all types. We see acute, subacute, and chronic. Oftentimes in America, most patients don't come until they're subacute, and their back is hurting them, or their neck is hurting them, or their headache just never goes away. And oftentimes we do see more subacute and chronic in the ambulatory setting. Whereas if we're working in the emergency room, we see more acute pain. So acute pain in the United States, and we'll talk about the Netherlands next, we have 100 million surgeries that took place annually, and we have about 6,600 per 100,000 people that have surgery. Of those, 80% of the surgical patients say they have postoperative pain. In the emergency room, 70% of all visits are due to pain. An acute headache in the emergency rooms account for 1.2 million visits. So in the pain that we identified in the Netherlands, this one study, here there was a moderate to severe general pain by the Dutch adults was 18%. The prevalence was 27 to 55% from any cancer pain. And 42% of the patients with general non-cancer chronic pain said they had been treated, but most of the time they were semi-treated. We'll see this in the next slide. So 43% of the chronic Dutch non-cancer pain patients received no treatment. 79% of the patients believe that their pain was inadequately treated. So in your country, in Holland, they're saying they're not getting adequately treated. Well, you can make a difference as a DO there. All studies reported said that the detrimental effect of chronic pain affected their life, their activities of daily living, their finances, their mental health. We all know that, but this study here in Holland proved it. So in Holland, they did a survey of acute postoperative pain. Was it adequately managed or inadequately managed? Again, 90% of the hospitals have the acute pain services, and they did all the right things, but still, there was still inadequate managed pain treatment for hospitalized patients. So in the United States, we know in 2019, there's pain everywhere. 58.9% of the people said they had pain in the last 3 months. Most of the adults showed that they had back pain as the #1 symptom, then lower limb, upper limb, headache, and even tooth pain and jaw pain. 10% of the population had it within the last 3 months. So chronic pain is very common for physician visits, and it's more prevalent in women, older adults, lower socioeconomic status, and people living in rural areas. The risk factors for increased pain include tobacco use, obesity, previous injury, physically demanding job, childhood trauma, depression, and anxiety. So what are the 3 diagnostic types of pain? We talked about pain, acute, subacute, and chronic. That's time-based. Let's talk about the diagnostic types, the types that we will be seeing as a physician more. nociceptal, neuropathic, and nociplastic. So nociceptic pain is sensory nervous system where there's encoding of the noxious stimuli. This sensory perception occurs in the peripheral nervous system. It's transmitted to the CNS for perception and recognition. So nociceptal pain is encoding of the noxious stimuli. Neuropathic pain is a lesion or a disease that affects the nerve root and transmits to the central nervous system. Nociplastic pain is ongoing inflammation, which can be caused by nerve damage. It's long-standing in nature. It can affect the nerve root. It's transmitted to the CNS for perception, recognition, sensitization, and entrainment that occurs in nociplastic pain, which is chronic pain. So here we have nociceptive pain that has that noxious stimuli encoding. It's a sensory perception through the PNS, transmits to the central nervous system for recognition. Neuropathic pain is a lesion or disease of the somatosensory nervous system where the nerve root level is injured and transmission to the CNS occurs. And nociplastic pain is caused by ongoing inflammation, tissue damage, neuropathic pain that's caused by nerve damage. Those are the three types: inflammation, tissue damage, and neuropathic pain that transmits to nociplastic pain. So it is long-standing. It transmits from the nerve root to the CNS for perception, recognition, and then sensitization and entrainment occurs. Sensitization, it represents an enhancement in the function of the neurons and the circuits of the nociceptal pathways that increases the membrane excitability and potential synaptic efficiency. It also reduces inhibition and is manifest in a remarkable plasticity of somatosensory system. So it's going to cause that membrane to be hyperexcitable and synaptic efficiency occurs. And the reduced inhibition then follows. Entrainment is an important characteristic where we have interactions between the brain rhythms. Coupling of the two independent oscillatory systems, they become related by virtue of their phase alignment. So that enhances and magnifies the perception of the pain. And entrainment is something that we as osteopaths often do when we identify somatic dysfunction, especially when we're doing gentle techniques like cranial techniques and energetic techniques on the patient. And so we can then help ameliorate the patient, but that's another story. We'll just talk about the NOR sensitization and entrainment today. So to review, we talked about the difference between pain and nociception. We talked that pain had the cognitive and behavioral and emotional component, whereas nociception was pretty much chemical, biological nature. We talked about good pain versus bad pain, eudynia, maldynia. We talked about pain as related to time, which is acute, subacute, and chronic, and the definitions. We talked about the diagnostic type of pain, which is nociceptive, neuropathic, nociplastic. And then we talked about the unique characteristics of sensitization and entrainment. And those are key effects that NOR can ameliorate. We're going to talk about neuroanatomy, neurophysiological review during our course in April. We'll also talk about the mind system. Now, I don't know if you know about the mind system. We'll relieve the neuroanatomy and neurophysiology for the real course, but here's just some things that we can talk about at this preliminary webinar. So we're just talking about sensory stimulation of proprioception, nociception. They go through the posterior horn and then through these laminas, 1, 2, 3, 4, 5, 6. And so lamina 1 goes to the lateral spinal thalamic tract and then to the thalamus. So we have the ventral posterior lateral thalamus, which goes to the somatosensory cortex. And then we have the intralamina medial nucleus of the thalamus, which goes to the cortex. And here we get our emotional pain center. Okay. So, but in the posterior horn, we also have these other lamina. We'll talk more detail in the course, but this is a spinal mesencephalic tract that goes to the central gray matter, cuneiform nucleus, anterior pectoral nucleus. And these transmit pain inputs to the medial thalamus, hypothalamus, and limbic system. Whereas the spinal reticular tract goes to medulla oblongata and affects the central gyrus. We also have mechanoreceptors of each of the joints and tendons and the spinal muscle spindle fibers and the gamma gain syndrome, where we have the muscle spasm. Well, these go to the posterior horn, gray matter, transverse to the spinal cerebellar tract, to the cerebellum. The cerebellum then feedbacks through the nervous system into basically ultimately into the spinal thalamic tract. And here we have the dorsal column that goes to the anterior cerebellar, spinal cerebellar tract to the cerebellum. So all these communicate, these joint mechanoreceptors, with the nociceptal pain fibers and proprioceptions fibers. So some of the other things that we'll talk about, I'll just briefly mention. We'll talk about the vestibular ocular reflex for gaze stabilization and head movement. Ocular cervical reflex, which connects the vestibular system and proprioceptive system. And NOR resets these neurologically back to normal in the pain centers, starting with the optic tract and descending into the motor tracts and then into the cerebellum, cerebrum to make them all normal. So we'll be talking a lot about all of these structures here in the real course. And it's very complicated, but it's very fun when you think about how unique the neuroanatomy is in the human brain and how we can influence that with our hands, enhancing the neurotransmission of basically health. So here is the mind system, which stands for musculoskeletal, the immune system, the neurological system, and the endocrine system. So pain has inhibitory or excitatory systems, and we can look at this here. So let's start with the endocrine system and the immune system and the nervous system. And then we have the musculoskeletal, which is the envelope. And of course, the fascia is the key point of all this interaction right in here between the muscles and the biochemistry of the body is the manufacturing index, where we just look at the influence of fascia upon the circulating hormonal cytokines, affecting the autonomic nervous system circulation, which then affects the autonomic nervous system circulation to the immune system. So the fascia and the cytokines influence the immune system. The circulating hormones influence the endocrine system, and the motor output of proprioception influence the nervous system. And they all contribute, these circulating hormones, to pain, these cytokines to pain, these peptides, diffuse peptides, into pain. So we're going to be talking about how do we influence this nervous system and to enhance the immune system, to mitigate the cytokine release, to mitigate the endocrine hormonal cytokine release. And we can do that with these gentle techniques called NOR. So what is NOR? It is neuro-ocular release. It's new in that nobody's ever talked about it previously. We have talked about using the eyes when I was teaching cranial courses in the 90s and the 80s to see what happens when you're doing cranial left torsion and have the patient look to the right, look to the left, see how it changes the fascia underneath your fingers in the dura. But we never put it all together. In 2016, I was able to serendipitously, as Many techniques happen, such as counter strain. Serendipitously, I had a patient that I couldn't treat a shoulder very well with, and I just said, well, let's do an indirect technique, and then let's have you look this way, and I felt the change that occurred there. And then I said, well, let's have you close your eyes and see if that makes a difference. And then open your eyes, and behold, all the pain was gone. And then I continued to work on that. And then 4 years later, I wrote the article that appeared in the journal. So NOR uses specific indirect methods that are combined with these ocular reflexes to reset the central nervous system through the peripheral nervous system, and also reset the peripheral nervous system in the spinal cord area also. So that relieves the pain. So it's an indirect method using a neurological activating force to amplify the normal treatment effect. So when a DO uses NOR, the monitoring of the nociceptal output, that tender point, is critical for the success of the treatment, because underneath your finger, you'll feel a change in the tissue texture there. And you'll feel, besides the little escape of extracellular fluid, you also feel the energy change right there. So after the tender point is found to be a maximum position using indirect techniques, standard osteopathic techniques, and some unique that are to NOR, you got zero pain. Then the ocular component is added and a greater ease is felt. So it really balances the ligament membranous tension. It can be a counter strain point. It won't necessarily have to be. It can be a facilitated release position, but doesn't necessarily have to be. It can be a pure functional technique. But anyway, it is always an indirect technique. So we have the patient position. We have them put their hand or arm or leg or trunk or head or neck in a certain position, depending on the point. We have them turn their head in a certain way, look at a certain point that's about the size of a coin, and they focus their eyes on that spot, so they have to stare, and they don't move their eyes, they stare, and that spot results in a maximum tender point reduction. You can feel the change underneath your finger. And that's what you're going to experience in the course in April. Then there's a sudden release. It's felt when the eye and the body is totally aligned, and that summation occurs. So this release is felt in essentially basically in 3 seconds, putting them in the right position, getting them in the right area, have them stare, then you feel the change, they're done. So they have closed their eyes. When they close their eyes, you return the patient back to the neutral position, and they open their eyes and you recheck the point. 99.9% of the time, it needs to be 0. You're going to find it to be 0 if you did it right. And that's all there is to it. We do the spinal thalamic tract and the cortical spinal tract. Is a simple, how do you explain it to somebody? Well, these are the 2 tracks that we're using, but there's a lot of interface that occurs in the central nervous system that we'll talk about in the course. So the key points for success is precise tender point identification, and then have the patient exactly in the right position on all 3 axes, X, Y, and Z. And the goal is to achieve maximum balanced membranous tension over that tender point, ranging the patient's body part to relieve all their tenderness in the XYZ axis. So this tender point, by definition, is a hypersensitive, moderately painful location in the myofascial tissues that do not have any specific pain pattern radiation. And they're used as diagnostic criteria and monitoring during the treatment. So here we have the exact indirect positioning, activates the peripheral nervous system through the spinal thalamic tract. Then they stare and in the right direction, activates and resets the central nervous system through the cortical spinal tract, sets up to have them open and close their eyes to complete that reset of the central nervous system and the peripheral nervous system, the spinal cord area, to remove that memory pathway. So it's essentially a warm boot of the computer, resetting your patient's brain and their perception of pain. And we're changing sensitization and entrainment in the patient that's suffering from pain. So here I have another video. This is the upper extremity, and I'm going to start out with some anterior points. We'll start out with the clavicle as it attaches at the manubrium. And I'm going to identify, is it tender left or right? Right. Okay. So we'll keep our thumb on the right tender point. Flex the arm all the way up. And when they're on the anterior part of the body, we have them look towards the tender point. So turn your face and look to the right a little bit more, 45 degrees. Stare at an object. Is this tender, yes or no? No. Close your eyes. Arm down, head straight, open your eyes, tender? No. This next anterior point on the shoulder will be the coracoid process. Identify the coracoid process in. Is it tender left or right? Right. Have the patient put their right hand on their forehead at the hairline, and that's it. And her arm is at a nice 45-degree angle. And because it's an anterior point, we're going to have her look towards the tender point. So turn your head to the right, look out the inside of your elbow, close your eyes, put your arm down, head straight, open your eyes. Tender, yes or no? No. The next tender point will be the glenohumeral capsule is up here, and then the coracoid ligament is found here. Is it tender here? Yes. This time, we're going to have her put her hand a little bit more into the hairline for the coracoid ligament, and turn your head and look at the outside of your elbow. Stare, close your eyes, put your arm down, head straight, open your eyes. Tender? No. Now I'm going to work on the glenohumeral joint capsule. Is this tender? Yes. Okay. And this time we're going to put the hand on top of the head and a little bit more over towards the side. Thank you. Turn your head to the right and look at the inside part of the elbow. Stare at my fingernail. Close your eyes. Put your arm down. Head straight. Open your eyes. Tender? No. And this is pec minor. Tender, yes or no? Okay, that was several techniques, and you can see how fast it goes. I was talking on the first one where we were explaining a lot of things, but once you get proficient in this, you can just do it within 10 seconds. You're all done with one point from start to finish. So it's very efficient, very effective. So what is the difference between this indirect technique and counter strain, balanced membranous tension, balanced ligaments tensions, FPR, myofascial release? Well, this affects the peripheral nervous system. Both of them do. This usually takes 3 seconds. The other one is 90 seconds. Patient cooperation is required. Practitioner technique is higher in NOR because you got to feel that little change. If you don't feel that little change underneath your finger, then, this is not a horseshoe and hand grenade technique where you just have to be close. This is specific. And then you have to have some vision, and overall contents are required, whereas counter strain isn't. And there's no known descending CNS pathway to affect the CNS sensitization and entrainment with counter strain, where it is with NOR. So conclusion. NOR is an advanced indirect osteopathic technique that puts into play the ocular nervous system and its related central nervous system, peripheral nervous system, as we described, to deactivate that central sensitization and local somatic dysfunction. Deactivation of sensitization and somatic dysfunction. It is utilized to inhibit the presynaptic primary afferents and postsynaptic inhibition of the spinal projections that modulate pain, resulting in fixing somatic dysfunction. It's less time consuming and more complete, I propose, than other techniques. It functionally removes that spinal cord memory, which is unique of all the osteopathic techniques. So you'll learn more on how to do these things in the course. What does the pain, how does it get to your brain? How does the ocular system initiate and reset the cycle so that you don't have that memory of pain? You'll learn how to treat all 10 regions of the body. You'll know what the indications and contraindications, whether they're absolute or relative. And you'll know about the complications from NOR. And we'll talk about clinical studies. So you're going to learn more about the nervous system, more about pain, all the details of the spinal thalamic and corticospinal tract. You'll learn how to put the patient in different positions for different areas of somatic dysfunction. And you'll all see that they may be counterstrain points or they may not be counterstrain points in the NOR technique. So we'll cover pain, all those systems, and the theory behind it, and how to relieve pain in 3 seconds. So thank you for your attention, and I hope to see you in April at the course.
Thank you very much, Dr. Feely, for this very interesting introductional webinar. I personally am very happy that you have developed some techniques to treat central sensitization, because for me personally, I was looking for this a long time, and so now I'm very thrilled that you developed a technique, and I'm certainly want to be in your class in April. So I'm very much looking forward to it. Thank you very much, and I hope to see you all in April in good health. Bye-bye.
Bye-bye.